delighted to be hosting this event and providing an opportunity to learn more about brain health and become empowered by knowledge. I hope you're able to enjoy some of the refreshment and try out some of the innovative neurotech tools coming to market. Now, for those of you who are not quite as familiar with the Ontario Brain Institute, or OBI as we call it, we're a provincially funded organization and we're focused on improving brain health through research, industrialization, and care. Ontario is very lucky. We have, in Ontario, a phenomenal number of scientists at the leading edge of brain research, over 1,000 neuroscientists here. And the role of OBI is to build and connect these strengths. So we want to harness the collective potential that already exists by creating an environment where people work together and maximize impact. In the past, research existed in silos, and translation from research to health impact has been slow. So we have a very simple approach. We get people together. We get them talking, we get them meeting, we get them working together, researchers, clinicians, government, industry, patients, and advocacy groups, all of the constituents, all coming together and creating an integrated system that will accelerate discoveries, deliver the right care, and improve brain health for all Ontarians, and indeed, we hope, for the world. Now, the OBI, however, doesn't carry out its own neuroscience research. What we do is manage research. We oversee research programs to help translate new knowledge into better practices. So currently, at this time, we have 5 research programs dedicated to these areas. Epilepsy is one. Cerebral palsy is another. Depression, and you get, by the way, if you follow the sense, you can see that we're looking at it across the age spectrum, but that brain disorders are also meant from the viewpoint of mental health, so depression. Neurodevelopmental disorders, and in here, we include attention deficit, hyperactivity, autism, obsessive compulsive disorder. We're breaking down the silos between diseases as well, and neurodegenerative disorders. And here, we're on the aging spectrum on the other end. We look at things such as vascular cognitive impairment, small strokes in the brain, amyotrophic lateral sclerosis, Lou Gehrig's disease, Parkinson's disease, Alzheimer's disease, and I think I got them all. And I said frontal temporal dementia. So what we try to do is keep the patient as the common thread. Our goal is to improve brain health. That holds the entire process together. So to do this, we've brought together patients and their representatives in a formal way to interact with our research programs so that we're not disconnected, so that research isn't an ivory tower. And ideas can be exchanged. We can get research ideas out into the community, but we can listen to the community about what's relevant and what's important. So each research program, each of those 5, has a patient advisory committee made up of patients, caregivers, researchers, and members of patient advocacy groups. These committees serve as a bridge between the researchers and the community. Today, in fact, we held our very first meeting to connect all of the patient advisory committees. So this is the idea of breaking down the silos. So we have patient advisory groups within disorders that we're studying, but we're getting even the different patient advisory groups to talk to each other, collaborate on a plan, how best to engage and integrate patients into our research programs, to inject the patient voice, to share knowledge, to improve care. So I'm going to ask Brenda Agnew, Director of the Patient Advocacy Links at 3-2B Foundation. Brenda was there at the meeting today. She's the member of the Patient Advocacy Committee for our Cerebral Palsy Research Program, and she participated at today's workshop. And so what we did is ask her to summarize and share a bit about the whole experience today so that you get a sense of the importance of the community to research. Brenda, if you would, please.
As was mentioned, my name is Brenda Agnew, and I am the Director of Parent Advocacy Link with a foundation called 3-2B. Also participate in the Family Advisory, Patient Advisory with CPNet. I also have a 6.5-year-old with cerebral palsy, so certainly have a vested interest. and everything that's going on with respect to that patient piece. So as was mentioned earlier today, I was honored to have been a part of a workshop. What was amazing about this workshop is that it actually brought together all of these patient advisory committees to talk about what our roles look like. What are our roles going to be like moving forward? What types of things can we go out there and have an impact on? What I found really amazing about it is that there was so many different groups represented. I mean, we talked a little bit about it earlier, but everything from autism to epilepsy to cerebral palsy, dementia, depression. We talked about our individual interests, but it was amazing to see the correlations between all of those different disorders. We spent a great deal of the day today focusing on the importance of sharing information and knowledge. So often, patient advisory groups are siloed. And even though we have common messages and goals, it's sometimes very easy to get stuck into what you feel is important. So what was great about today is we had the opportunity to break down some of those silos and actually talk about what those common interests are and what those common goals are. We also had great opportunities to discuss what has worked and what hasn't, and learn from each other. There's groups that have been around for a lot longer than other groups, disorders that are relatively new in their diagnosis versus disorders that have been around for a long time. So it was wonderful to be able to hear, again, some of the challenges that people have had, but then some of the successes that they have had. And if we can learn from one another and not recreate the wheel, it gives us a better chance moving forward to be more successful with some of our goals. So I wanted to summarize a little bit about some of the key realizations that came through today. And it's my hope moving forward that a lot of these realizations will translate into tangible goals that we can work towards resolving. A big piece today was around knowledge translation. What does that even mean? It's a buzzword that's out there, but we today got a very close-up definition of what that looks like. How is it done? What are the best practices? How do you work on keeping that current? So that was really, really important for us because, representing that patient population, it's so important to have that knowledge, be able to understand that knowledge, disseminate that information, to keep everybody abreast of what's going on. We talked a lot about working together to maximize our outreach. When I first had a child diagnosed with cerebral palsy, I had no idea who was out there speaking on our behalf. I didn't know what CPNet was. I find myself to be a fairly resourceful person, but I had no idea that this larger organization or this larger entity existed. And all of a sudden, I was made aware that there were people out there that were looking into research and putting best practices forward, and they were looking out for the best interests of those patients. And that was true for all of those groups that were there today. So maximizing our outreach so that people know that we exist and that we have this important role is a huge piece of what we need to work on. How can we have the greatest impact for patients with brain disorder? Is it research? Is it knowledge? Is it education? What does that look like? What do we need to be working on that is going to have that biggest impact? How can we influence researchers from the patient's perspective? There's amazing research that's going on out there. It's important research. We need to drive that forward. But, looking at it from the patient's perspective, what's important to the people that are actually, that actually have these disorders, or the families that have individuals with these disorders? What's important from their perspective from a research initiative? And then further to that is getting feedback on that research. So, it's amazing that this research is going on, but sometimes it's not made apparent for years and years. Or there's research studies going on, the information being disseminated is not clear. You have no idea what the specifics of that research are, or what the impact are going to be. So finding ways to actually get feedback and give feedback on those research projects. And just, again, to talk about how do we best disseminate key information. We talked a lot about family and stakeholder engagement, such a huge piece. It's not just the patient, it's also the whole spectrum around that patient that we need to be cognizant of. And finally, we wanted to make sure that we could have ways that we could create more dialogue between patients and researchers. The reality is we speak a different language, and that's okay. Scientists speak their language, clinicians have their language, we have our language, and it's important that everybody be able to communicate within their individual worlds, but how do we find a way to get a language that we all can understand and communicate with one another? So I know that not only being a part of this patient advocacy or patient advisory committee, but being a parent, I personally feel energized and enthused at the possibilities that were brought forward today. And I think it was a positive step in creating a more patient-focused environment as it relates to brain health and its associated disorders. Thank you, and enjoy tonight's lecture.
Dr. Tiffany Chow is a senior clinician scientist at the Baycrest-Rotman Research Institute and staff behavioral neurologist at the Sam and Ida Ross Memory Clinic. She also holds a dual appointment as Associate Professor of Neurology and Geriatric Psychiatry with the University of Toronto. It's always been a source of pride for me that I'm the one who recruited her to Toronto and to Baycrest, on the basis of her dancing, I will have to say that. No, it's on the fact of that she is a caring and wonderful clinician scientist. She's an expert in diagnosing and treating early onset dementia and is heavily involved in the community to increase awareness of dementia and its prevention. Today, Tiffany will be sharing with us the similarities between all of us touched by brain disorders and perspective on how to become empowered by self-compassion. So I'm very excited and proud and pleased to have Dr. Tiffany Chow here. Please welcome Tiffany.
People in California were taking bets as to how long I could last. I must say this winter that we are enduring together is a doozy. But Don has always been there for me. And right on up till tonight, I needed a Kleenex. And he had a clean one in his pocket. Okay, so let me get to, that slide is showing, yes, that's the name of the talk. And here's some objectives. I'm going to start with something that I feel helps bring us all onto the same page. Many of you have been here for the workshops earlier today, so you've created a little sense of community already, but I'm not in that yet. So I want to get in there with you. I had the opportunity to go to meditation camp for a week. Thich Nhat Hanh, who I mentioned in the book, is a Vietnamese Buddhist Dharma teacher who has his main posse hiding out in Bordeaux, France, which doesn't sound bad at all. And I thought this was going to be the year that I was going to spend a week on retreat in Bordeaux, France. However, when I Googled what was going on and where the man might be this summer, it turned out he was going to be at St. Catherine's at Brock University for a week. So I was one of 1,400 campers. That means 2,800 shoes out in the hallway. The space was maybe another 100 feet in that direction. Most people sitting on the floor, but many people sitting up in chairs. And one of the objectives for this particular camp was to talk to those of us who are educators about how we can teach young people, or just others that we're responsible for, a bit more about mindfulness. And one of the sample lectures by Thich Nhat Hanh was so very pertinent to where you and I all want to be. As care providers, whether we are informal family members or people who have trained and gone to medical school or nursing school or become PSWs, we want to bring something good into the room with us when we are with the focus of our attention. We need to bring our best intentions, but we also need to bring our skills. The road to hell is paved with good intentions, right? So one of these little mini lectures for kids, I decided I'm really going to have to repeat that. You know that in most spiritual sessions, there's some sort of alert that brings you into the quiet space. So in Buddhist temples, there's somebody who's ringing the bell. Sometimes it's a big bell, sometimes it's a little bell. But to be the bell master, you don't just get assigned because every week it's somebody else. It's not like the kitchen patrol duty. It's something that you actually have to study because you're not smacking the bell. You're not actually even ringing the bell. You're inviting the bell to sound. It's a whole different context, isn't it? And the reason we're inviting the bell to sound in this context is not alert, there's a fire, get out of the building. It is, we want to all remind ourselves of the better intentions for why we're here and focus as well as we can to use our best skills to make that happen. So he's telling these little kids that are sitting in the front row, okay, so you have your bell, and in this case I have a bell that has two aspects to it. And you actually respect the bell because you understand that it has a purpose and you have to work together. I've got a whole bunch of foof on this, so I'm respecting the bell by getting rid of the foof. And I have to stop. You have to do a check-in with yourself. Okay, the bell's in working order, but how am I? Am I in a good place so that I can help this bell, invite this bell to sound? Or am I still somewhere on the TTC where somebody pushed me and I'm just being mindful, not saying something? And then when I'm ready, I take a breath, and I don't want to blast you by putting that in front of the thing, but okay. I feel that you're ready because I've chatted you up, and I'm ready. In this moment, we have all been quiet and supportive of each other. And everybody's been safe and in the same place. And that is one of the best goals of caregiving, right? So when you're caregiving for 15 minutes, it's pretty easy. But in the context of many of the patient advocacy groups that have been coming together today, it's much more difficult. The needs keep changing. The days are unpredictable. It's tiring. You're not at your best all the time. You can't be. And so some of the things that we'll talk about today is to try to help bring you to that mindful, calm ability to do your best. Now, I'm also going to give you a different kind of sample. I highly recommend this book by Andrew Solomon. It's called Far from the Tree. And I love many things about it. Each chapter represents the research that he did interviewing parent-child dyads. So one parent and the child. The child is incredibly different from the parent. So when the parent is trying to be supportive of nurturing to the child, is a big challenge because there's a very wide differential between my life experience and what I imagine that this person is going through. And sometimes it is from not understanding, from lack of knowledge, that fear arises. Fear that you're going to be a bad parent. Fear that that other person might try to hurt you. All kinds of different things. And the book is about how all of these interviews put together, children born as a result of rape, dwarves, child prodigies, children who are deaf, gay children who were born to straight parents, how it's the diversity of the people that you're challenged to love and or accept that actually brings out what's most human in us. And I'd like to share with you a really fabulous video clip, it's very brief, of an interview with one such parent-child dyad. Can we cue that up, please?
Chris is in 11th grade. All right, Chrissy, go to mom. Let him walk off if you don't mind. Yeah. Go to mom and I'll be off in a minute. Go to mom. Chris probably had one of the worst diagnoses ever. Self-injurious, swollen intestines, poisons in his systems, neurological damage, mental retardation, severe autism, almost the Crohn's disease. Chris did not communicate. He didn't sit down. He didn't put on clothes. He wouldn't go outside. He ate the walls. He ate the table. He ate the rug. We couldn't eat in the home. We couldn't have lights on. We couldn't have the TV on. If I coughed, he would run downstairs and punch me. It was a 24-hour day job. Chris never slept. He never ate. He wore diapers, never spoke. And I was pretty much told to put him in an institution. The thing I've learned most over the years is to be a parent first. It changed my life completely, put me in another direction. I was able to love unconditionally. And I never thought of him as this poor, broken human being that we need to cure. You know, he's not sick. You're trying to get me to go?
It's a remarkable clip. I know that all of you who are caregivers have had that wonderful experience of being able to be with whatever it is that's going on. This guy has come a really long way. He needed to be educated on what was going on with his son, has to work with doctors all the time. But it was so remarkable to me that his comment at the end there is, that he's not sick. It's fantastic. That is that embrace of the acceptance of what it is and loving the situation, which is not something that everyone can do. I bring up Buddhism just because it means different things to many people. For some people, you're familiar with the sculptures when you go to the museum. The sculptures are of a very calm, transcendent figure. But one of the interesting points is that Buddhism is meant to be practiced in difficult situations, during traffic jams, in conflicts with other people, not necessarily as a monk who's tucked away in a temple and whose day job it is to meditate. Some people think of the Dalai Lama. One of the things that I think of when I think of the Dalai Lama is that he has a fantastic sense of humor. There is a joy. That's something that's common across all of the religions, is the joy of community, the joy of having something valued that can be shared. I also think of vegetarianism when I think of Buddhism. But that's actually not a requirement, which I'm very glad of. There are many reasons why it makes sense if you're following all the tenets, but it's really not about being a particular set of rules follower. Instead, people who endorse each of these 4 values are pretty much on the same page and are probably Buddhists. I put the quote, "It comes in 4s," just because when I moved to Canada, I recognized that everybody was saying, "It comes in 3s. 2 things happen. Oh, well, it always comes in 3s, eh? So in this case, it comes in 4s. I caught myself texting someone earlier today that ubiquitous question, cold enough for you? That's another Canadianism. Anyway, the components of enduring love, regardless of whether you want to call yourself a Buddhist or not, are up here. I've translated them into English for you, and they are loving kindness. In all positions where we're trying to provide care, we're trying to provide loving kindness. We are absolutely trying to show our compassion. Sometimes we forget, though, that there should be some joy embedded in that provision of care. If you do it without joy, it creates an awkward dynamic. The person on the receiving end may feel guilty, may feel some kind of strange vibe along with that, and we want to avoid that. We want people to know that it makes us happy. There is something wonderful to be gained in this caregiving interaction, and therefore it's not a one-way thing. I'm actually getting something that I want out of this. I'm getting to know you better. I'm getting closer to you. It is my joy to help you. Equanimity is the other thing that very frequently gets tossed out the window or left behind. Equanimity is trying to take all things the same. Another way of saying it is no discrimination. I'm not going to cling to those things that are easier and more pleasant for me. I'm not going to cling to despising or avoiding those things that are uncomfortable for me. And sometimes that means you need to exercise some of this compassion towards yourself in order to navigate the long course ahead. So when I translate these 4 concepts into what are the minimum requirements for the patient at the end of the day, it's very difficult for some of our caregivers to feel comfortable and to feel like they actually did what they were supposed to do at the end of the day, because they feel like they need to research the internet very frequently to see if there's an extra thing that they left unturned, whether it's a clinic or a new drug or a clinical drug trial. They try to make sure that everything is smoothed for the patient in terms of how the day is going to go. Maybe there's a little bit of over-programming going on, consultations with other people, managing the personal support workers who may also be helping. There's a lot going on, but sometimes we, as the healthcare professionals, need to remind the caregiver of what the bottom line is for feeling like, yes, I did take care of the patient well today. As the caregiver, a person knows the patient better than any of the healthcare workers who only spend 15 minutes at a time with the patient. We need you to translate for us whether that patient seemed to be in pain, whether it's physical pain or emotional pain. We want them to be pain-free. We want them to feel safe. In the context of a dementia or a mental disorder, that may mean that we need to address any kinds of delusions that are causing fear in the patient or creating anxiety. Meaningful activities. These may need to be adapted to the abilities of the patient, but it's really important for them to have some sort of meaningful activity. And that may or may not mean a social interaction. Some patients will do better if they're left with the dog peacefully in the sun in the window for 10 minutes. And we want to provide maximal autonomy, choice where decisions can still be made by the patient. Most caregivers, without nursing training, without medical training, without pharmacology, can make this happen. And it is my hope that their healthcare providers have made it clear that they do have access to using medications or asking for consultations to make these things happen. But really, at the end of the day, these are the only things that a caregiver is responsible for. At the same time, the caregiver wants to have a meaningful interaction with the patient. And the healthcare team is there to try to facilitate this, whether that's through translation of instructions on how to care for the patient, or in terms of reminding them of the items in the left column so that they can relax a little bit more. When you bring your tense self into a situation, it has a ripple effect. And so we need to help the caregivers to focus on what they can do, get a feeling of mastery, and then they can move on with everything else that needs to happen during the day, so a lot of which may not have to do with direct patient care. So we know that it's important to have an emotional connection, and we need to remind caregivers of what the patient's current abilities or skills are, so that the hand squeeze is that emotional connection. It's not going to be a conversation. The patient's not giving you the silent treatment. It's just really not a talking day today, or we've lost language ability. We understand that caregivers want to feel that they are actually able to do something for the patient. And sometimes that translates to being able to feed the patient. We did some comparisons between California Alzheimer's disease families and Chinese in Hong Kong and Taiwan. And it's very interesting that I come from a culture where food is really important. Food is more important than memory. I don't care if you remember my name. I don't care if you recognize that I'm your daughter. But if you're not going to eat your favorite soup, now I'm worried. And I don't think that's only a Chinese thing. But it might be that the most important thing that we as the healthcare professionals can do is to help you to modulate so that there is a successful meal going on and going down. We remind caregivers that the bonus is not in the coaching, prompting, getting the person to remember what day it is and what floor of the building we're on. Really, the best thing that you might be able to give this patient is a space where he or she is not alone and feels completely accepted as he or she is. It's hard to do if you, the caregiver, have not yet accepted that this whole situation is going on. If you have not accepted that there is a diagnosis, it is a neurological disorder or a major mood disorder, we do need to face it, and then we can actually be in it together. For most people who can vocalize what is most terrifying to them about their chronic or their terminal illness, it is the idea of being alone, of being abandoned. Not, oh, I'm going to lose all my memory. It's, I'm going to be abandoned. You think about cancer patients. They're worried about pain, and they're worried about dying alone in pain. We need to reassure the caregiver that everything that can be done is being done. It's not fair if the healthcare team leaves it to the caregiver to reassure himself or herself of these things, because it's just so impossible to know. That's what the team at large is for. That is why we are keeping up with the research, so that when you ask, okay, is there a drug that we haven't tried yet that we should be using, we should have an answer for you. Sometimes in terms of caregiver coping, we need to adjust the focus away from the patient did this behavior, the patient did that, making it really hard. I keep telling him not to do that, but he keeps doing that. Sometimes we need to reflect on how is this happening? There are two of us in the room, and not just one actor. We are both acting, and we are both adjusting each other's behavior by our actions, even by our silence. So when we can, in our memory clinic, we will separate the patient for an evaluation from the caregiver and try to adjust the caregiver's lens to, okay, so what exactly is the activity that you've noticed, as opposed to what your interpretation of it is. So whether you're dealing with children or older adults, one of the things that can happen is sort of a purposeless, repetitive behavior. And sometimes we hear about that from the caregiver as, oh, he's really anxious. So most people would take that at face value and then give an anti-anxiolytic drug, which actually usually ends up being a sedative drug. And that's not quite getting at the behavior itself. So we need to teach, what do you see? Well, I see him opening and closing the drawers. And if I take him into another room, he's still opening and closing drawers. Does he look like he's going to cry? Does he look like he's getting sweaty or out of breath? No, he's actually pretty calm now that you mention it. He just keeps doing the same thing over and over again. Well, that is a man who's looking for something to do, not necessarily an anxious. So then that helps open a door that we can all go through together. Sometimes it takes a long time between the diagnosis and the time at which, and this is different for all caregivers, the time at which we accept, okay, this is the new path that we are on, and this is what that path means. So that's several steps, actually. There's, okay, I heard you. I can say this word in a sentence with in the same sentence as the name of my loved one, but what does this actually mean? What am I giving up? Am I giving up our retirement travel plans? Am I giving up all these Sunday mornings reading the New York Times together? What exactly has been lost? And we need to create space for caregivers to reflect on these things and go ahead and be sad about them and not hold it back or sweep it under the rug until a later time. This is actually what self-compassion and mindfulness are about. Being with all of those different feelings that are all very human, but acknowledging them, giving them a place so that none of them are lurking in wait and manifesting in different ways as impatience with others, maybe not the patient, but erupting as some other poor skill. Even though your intention is good, again, if you're not all embracing of the situation, it's hard to address it in the best way. The 4 items that were in the, let's see, I can use this clicker here. The 4 items in the patient list also translate to, do you, the caregiver, feel safe? Do you feel loved? Do you feel happy? Do you feel healthy? We should all be asking ourselves this at the end of the day. Because if the answer to any one of these is no, whatever you're doing that day is not really sustainable over the long run. And for all the intention we have of providing good care, we're not going to last very long or be able to provide the best care unless we're in a good place ourselves. Someone I was talking to recently was discussing how guilty he feels that in his marriage, he's the yeller. He's this awful person because he's yelling all the time. I said, well, what are you yelling about? And it's the same argument over and over, but the other person will not stop doing what they're doing. So there's yelling. And I said, you know, I appreciate that you're blaming yourself for the yelling because we don't want to be yelling, but do you feel safe? And the answer was no. Even though he's the acknowledged culprit, he's yelling because he doesn't feel safe. So as caregivers, you need to ask yourself, why don't I feel safe? What can I do to feel more safe? Whether that's a physical kind of safe or an emotional kind of safe. We all have different thresholds for having a surprise in the day, and that's okay. The thing is, if you don't feel safe in your current circumstances, then you do need some more help. And that's the part that we need to hear about so we can help make that happen for you. One of the challenges for caregiving for someone who cannot communicate very clearly with you is that sense of, do you feel loved? If that's the one person you're spending every day in and out with, you may actually be behind on that feeling loved part. But what we really mean by that is actually, if we had the time, we would go over this checklist with you. Do you feel safe? If not, why not? Do you feel loved? If not, where can you go for that? It's controversial in some families, but I have some spousal caregivers who have a girlfriend or a boyfriend who's helping them to navigate the placement of the loved one in a long-term care facility. But that person feels loved. That person may feel a little guilty because the kids don't feel good about this other relationship going on, but in the long run, the sustainability of the caregiving, this person needs to feel safe, loved, happy, and healthy. That person needs to be able to walk into the long-term care facility for a visit, happy to be there, as opposed to obligated. So we need to keep track of taking care of ourselves because it's nobody else's responsibility to do these things. There are a lot of people who get into relationships hoping that the other person will take responsibility for protecting you, for loving you, for making you happy, and looking after your health. But actually, these are decisions that you have to make. And it's sometimes hard to balance everything to make it all come out right. But this is really key. It's key whether you're a family caregiver or a professional healthcare provider. Many of us in medicine lose our sense of balance. We're so busy trying to take care of everybody that we don't have balance. And then we're poor examples of how to take care of yourself. And we're grouchy with our staff, with patients, with caregivers. So it behooves us to try to set a good example for everybody that we're trying to teach about these things, which are actually possibly more important than the prescriptions that we are writing. Unfortunately, the medications that we use for almost all of the disorders that were discussed earlier today, except for maybe epilepsy, are so-so in terms of their efficacy. But this kind of mindfulness has a pretty much 100% hit rate, as long as we can sustain it. So master caregivers, whether they're caring for children or caring for adults, they need that emotional connection and quality together time. But that can only come if you can adjust your expectations and have a better understanding, much more of a perspective. This is where the equanimity comes in. Understand where conflict arises. And I'm sorry it's a cliche, but pick your fights. I know it's annoying that he keeps tapping on that glass the way he does, but actually he's safe. For some reason it makes him happy to do that. And he can actually do that in a room by himself while you're taking care of something else, as long as you're not concentrating on how annoying that is. Instead, let's have the argument when he's going to try to cross the street by himself without looking both ways, because we're trying to keep everybody safe. Doing for. We can help you if there's a difficulty with eating. There are speech and language consultants who can help with swallow evals. If there's certain times of day that are better for eating, then we can try to help you be cognizant of what a new routine may look like in order for it to fit in. In terms of being sure that everything that can be done is being done, those caregivers who have a little bit more time and energy often will advocate for the patient and others. And actually, I think that includes everybody who's participated in the workshops today. That's what you're doing in gathering into this community. There's a book called Unlearning the Basics. And it's written by a guy who did his religious studies degree at University of Toronto. And the take-home point from the book that I really took to heart, and which is consistent with the message I'm trying to give you tonight, is we all have a running narrative in our heads about ourselves. Some of my narrative is what Dawn said in my introduction earlier. But a lot of my narrative is other stuff outside of what I do for work. And the narrative changes over time. You add more things, you subtract some other things, you do change your priorities and whatnot. But the thing that we want to avoid in the narrative are all those sentences that start off with, I'm the kind of person who always, or I'm the kind of person who never, because that shuts a lot of doors. We are living lives that are all about change. And Yesterday might have been a really horrible day, and that does not guarantee that today will be a better day. It could be an even worse day today, and it could be an even worse day tomorrow. But it's not always going to be one way or the other, and you're not always going to be one way or the other. Some of my friends who are more neurotic function very well with that neuroticism. However, they get into trouble when something runs counter to the narrative. I'm the kind of person who always gets myself out of trouble. There will be a time, there will be a trouble that you can't get yourself out of. And you have to open yourself to that possibility. That time when you may be less independent and have to reach out and ask other people for help. One of the big challenges for our caregivers is, I'm always running the household. I'm always doing this, and I love it. I'm really good at it. I'm the best at it. I'm always the person that he wants to be with. You see where I'm going with this. We need to remain open to change. The caregiving experience, and I think this may apply more to those who are caring for children than for older adults, because you're always a parent, is that it's a marathon. It's really long, long distances. And Ironman athletes have an advantage over you in that they actually volitionally train for this event ahead of time, like for years ahead of time. And then the event has a beginning and an end. There's a start and there's a finish line. And you know exactly where you are along that course. Oh, I'm on my bike now. Oh, now I'm running. Only 23 more miles to go. But I will get there before they close the finish line. Or they've closed the finish line. I can get my friend to come pick me up on a motorcycle. Caregivers, real caregivers, don't have that luxury. I have a friend who qualified for the Ironman at age 42 and finished second in her age division. I was incredibly impressed. But the other thing that I learned, as you might be able to tell, I'm not really shy. I actually got a job as a volunteer at the transition area. So I was holding the cups of water and Gatorade. And the only instructions they gave to the volunteers were, remember which hand has what thing in it, and the athlete, as they're running by, because they're about 45 seconds max in the transition area, will say what they want, and you just hand them the cup. So I was like, yeah, I'm all over that. That's only two things. I can do that. Well, as you can see, we're standing there. The athlete is coming in at X miles an hour, or kilometers per hour, and your stationary object, he or she is moving, and you've got cups of liquid. So you end up wearing either the water or the Gatorade. And at the end of the race, I was talking to my friend and some of the other racers, and I said, so they told us to basically just give you what you want. And they laughed because they said, we don't know what we want. We just need something. We just want you to give us something, and we're going by. And that's actually what my experience as a neurologist in a memory clinic is like. The patients and their families are cruising in. They got 20 minutes to tell me something, and I got to give them something, anything, give them something, and then they're gone in a flash. And I get everything splashed on me, and wipe my eyes off, and then say, okay, what just happened? So one of the things that I am trying to do as the clinician is to provide at least a sense of we're going to slow down, and we're going to be here together. And I'm just going to sit here and listen. And one thing that is missing in many clinical venues is that I'm just going to listen to you. I'm going to let you just go off. And one of the things that I found very effective is to reduce the, okay, well, you can do this. Okay, well, I think you should change that. Because sometimes all of the help is in the listening. And very little of the help is in, oh, but you didn't do this yet. Ah, but you should try that. Because I get a whole bunch of resistance when I try to do that, because I'm not the person who's been living with them for the last 4 months in between appointments. Those things have been tried or have been considered. The caregiver really needs to be able to debrief. And that is where our, for lack of a better word, our sister resources come in handy. So Alzheimer's Society, some of the other advocacy groups that have gathered here today, you really have a voice, you can use it, people will listen. And that's very important. I understand the significance of offering that. So you don't get to prepare for the marathon ahead of time, but there are some things you can do to sustain yourself so that you're going to make it through the whole process. And these are each covered in the book, actually, so I think each of you got a book. You can read the details about it. But the main thing behind all of these is that you need to be safe, loved, happy, and healthy. So stress. There's good stress, actually, and there's bad stress that you're unhappy about, that you have no control over. Things happen to you, and it takes away your sense of your narrative, maybe even, challenging to the narrative that you've created about yourself. So stress management has to do with the mindfulness, has to do with actually the acceptance of whatever it is that's stressing you out. Once you can accept it, then you can actually, as Donna was saying, dance with it. And that's a management. That's being with the stress, understanding it, so that you can minimize it. When you are too stressed out for too long, cortisol is released by your body. Cortisol is actually quite toxic to your hippocampus. And it doesn't matter how old you are. So everybody in the room, we all suffer the same kind of change when there's too much cortisol. Now that's just one of many things. If you feel like you've been gaining weight, they call it truncal obesity, so in the middle of your body as opposed to all over, that's actually cortisol. If you are, you can actually drive yourself into a state of osteoporosis. It changes the way you release insulin. It may actually enhance your risk of getting type 2 diabetes. There are all kinds of reasons why you don't want too much cortisol. It's okay if you got cortisol for 3 or 4 hours on a day where there's a big event, but we don't want this as a chronic state for you. So I don't say manage your stress just because I want everybody to be more mindful. I'm saying it because this is something that preys upon your memory ability as well as some of your other physical functions. The good news about this effect of cortisol in the hippocampus, and hippocampus is where new information comes in, gets sorted, filed, and cross-referenced, is that the studies show that high cortisol levels shrink that hippocampus down, but if you remove that high level of cortisol release, it puffs back up again. This is good. So it's reversible, okay? And we're gonna talk a little bit more about these other things on the next slides. But the main idea here is, what are we gonna do with ourselves on a day-to-day basis that is sustainable and brings us into that safe, loved, happy, and healthy space? These all sort of feed into the concept of cognitive reserve, which I think, how many people have heard of cognitive reserve? The newspapers are doing a very good job of talking about it. Cognitive reserve is the amount to which your brain has resources, or collateral function, if you will, to resist functional changes despite the fact that you get injuries. Okay? So an example of this would be results from the nun study that was centered in Chicago. A particular order of nuns signed up for autopsy. And the order had all kinds of records about their health and actually had their entry essays as novices. And the nuns who had more cognitive reserve, as measured by how articulate and complexly organized their essays, their entry essays were, could have changes of Alzheimer's disease in the brain under the microscope at the time of death without showing the outward functional loss, memory loss, confusion, difficulty in space or remembering things, the cognitive global deficits. So there are many of us who are going to develop changes in the brain as we age. Abnormal protein buildups will occur. But that part isn't as important to us and our quality of life as being able to power through anyway, to compensate for those changes. The more cognitive reserve you have, the more likely you are to be able to compensate for what might look under the microscope like full-blown Alzheimer's disease. So that's the hope. That's the thing that we have more evidence for now than any treatment to unbuild the abnormal proteins. So the the interesting research papers, and actually OBI published a review of the physical activity effect on helping to prevent advance of Alzheimer's disease symptoms or even getting the Alzheimer's symptoms. So cognitive reserve allows us to compensate. It's not just how much you know. That's a different thing. It's about how your brain works to traffic the information that's coming in. It's about mental flexibility. I told you before about that personal narrative of I'm the kind of person who always blah, blah, blah. That's one kind of mental inflexibility. But mental flexibility to try new things, to learn new things while maintaining those things that you are already doing well, that's how cognitive reserve is built or maintained. And it really speaks to your adaptability in times where you need to problem solve or manage your emotions despite something terrible or something really fabulous happening, and your behavior. And it's part of the conversation about Alzheimer's disease because there is a chance that you, like my grandmother, would have Alzheimer's disease pathology, but continue to lead life as it was 20 years ago. That's what I'm aiming for. You know, people ask me, oh, aren't you scared that you have a family member with this illness? Actually, that doesn't bug me so much because she was exemplary. She's sort of like the poster child for Alzheimer's disease, lived well. But I do need to get on all these things that I'm telling you about tonight. I'm pretty good, you know, on a scale of 1 to 10. I'm about at 8.5 today. I was about a 10 2 days ago, but I was on vacation. So, and some of these things that we're going to talk about in the next few slides hold resonance for just quality of life in general. You know, even if you didn't want to worry about, oh, what's going to happen to me 20 years from now, these are things that actually help people to feel on a daily basis safe, happy, loved, and healthy. And I do mean to include mood disorders. Recurrent depression is a major risk factor for dementia. We need to keep this in mind. We need to help those around us who are suffering depression because it creates a different threshold for secreting cortisol. And we'll come back to that in a moment. At a molecular level, the recommendations speak to what the brain needs. The brain needs glucose and the brain needs oxygen. So we need to keep the flow of those items in the blood strong to the brain, filling the squash, as I like to say. The other thing that I told you about before, that flexibility, the adaptability, the cross-referencing of information, is like increasing the number of hubs that your airline is running. So if you were flying this airline and there was a huge hurricane headed for Georgia, you're hosed, right? Because you're not going anywhere. All your flights can't get to the hub or get out of the hub. You're not connecting, you're not arriving. But if you have an airline that has many hubs, then you have lots of different alternatives, okay? And when you learn how to solve a problem in 3 different ways, when you do one more type of dance, not just the one that you've been doing since you were a teenager, all these things help to build collaterals for the functions that you want to do as your quality of life, whether they're hobbies, whether it's your job. There's also, at a molecular level, this sense of abnormal proteins. So I'm using the example of Alzheimer's disease because we have done a good job of figuring out what seem to be the culprit abnormal protein buildups. There's plaques made out of amyloid protein, and there are tangles, which actually hang out inside the neuron, and they're harder to get at, therefore. The tangles are made up of tau. Now, you and I, don't panic, you and I are making amyloid right now. It's not this kind of amyloid, though. It is actually folded in a different way. Are you familiar with origami? Okay, so you know what the crane looks like. Have you ever tried to make one? If you make one wrong fold, it looks like a frog or it looks like a crumpled piece of paper. Our brains right now are making the cranes. But at a certain point, a signal goes out and you start making the lumps and the frogs. But the same person with this same brain, was sending me emails that were quite coherent, and he was still working at the time that we diagnosed him with a dementia. He wasn't working as independently. He needed somebody to clean up his legal documents, but he was doing fine, and he continued to do quite well for another 3 or 4 years. I think it was in year 4 that he actually drove his car into it wasn't a ditch, it was like a real hole, like the whole car went in because he didn't really understand the detour signs. But this guy had cognitive reserve in spades, okay? So how are we going to build up or maintain this reserve, and how are we doing on time? Okay. People first think that it's genetically related, whatever it is, whether it's your child's illness or something later in life. And that's sort of true and sort of not. And I don't know if you saw this movie. It was a beautifully shot film called Gattaca about how in some dystopia of the future, as you're born, your foot gets stuck to do a blood sample, and then this long ticker tape comes out. Your mother isn't even holding you yet. And the ticker tape tells you, based on your genome, what your risk of developing whatever disease at whatever age is. And there's a whole bunch of discrimination going on. So the main character has a 33% chance of dying of cardiac arrest in his early 30s. And so he's denied jobs. And his dream, though, has been to become an astronaut. So what are we going to do with this? Well, it's a 33% chance. In each of the dementias, we're having a hard time explaining who got an illness based on just their genetics. So there's a lot more things going on than just looking for one gene that's causing your disease. There are gene plus another gene equals trouble. There's gene that would ordinarily be bad for you is counterbalanced by another gene that actually offsets that problem. And then there's the combination of your environmental exposure and your genetic vulnerability. So some of your cognitive reserve is going to be genetically based, so you can thank your parents for the gift they gave you. But you still need to do something besides just resting on your laurels. So early in life, there's a high association between the level of formal education and cognitive reserve, the diversity of your experiences as a child, for instance, bilingualism, but world travel may be something. Having an encyclopedia in your home, which I think is not happening anymore because we can Google. But those of us over a certain age remember having to look at the encyclopedia to do a school report. Actually, having your parent help you with your homework is a real big factor because you're learning a couple of different ways to solve the same problem. There are different kinds of intelligence, and I've got a slide for that in a moment. There's social networking, being part of something meaningful. I put that in italics because the data so far have to do with studies conducted on older people and risk of dementia, but it seems to me that this should probably be what's going on early in life as well, especially because if you are brought up being a social networker and working on teams, learning teammanship, then you're more likely to do that when you're older. The evidence points to social networking and leisure reading. In fact, there's a sense that you can compensate for your elementary grade school educational level as your max by being a reader later in life or throughout your life. Social contact is really important. The risk of getting Alzheimer's disease, in particular, if you report feeling isolated, is actually as high as the risk when you have diabetes. So it's important that people do not feel isolated. Now, some of us like alone time. That's a different thing. Feeling isolated. And people who feel isolated do not necessarily meet criteria for depression. So we're not talking about just people who are depressed. This is a very interesting and important point. And it's hard to become a social butterfly if this wasn't your lifelong pattern. So we need to advocate in our schools how people can feel a sense of community, whether that's a community of 6 or a community of 60 or 600. Part of the evidence in this direction also is that widowers tend to fare poorly over late life. Affiliative behaviors, and actually some of these are the same stuff that is in the book by Fulgham. Share things. When you go out in the world, go together. Say you're sorry when you hurt somebody. Don't take things that aren't yours. Play fair. Don't hit people. flush the toilet. These are things that we often can take for granted, but they are things that we do in order to get along and to not feel so isolated. Different kinds of intelligence. Now, this is something that really fits in when we are trying to enhance or adapt activities to enhance or maintain quality of life for our patients, whether they're young or whether they're old. The child may not be able to develop a verbal intelligence. However, that child may be musical in ways that far surpass their language skills. Orienting your body to space. Athletes, our Olympic athletes, are really geniuses when it comes to orienting their body to space. Not everybody has a lot of emotional quotient. That's our, unfortunately, the stereotype is that engineers are not going to be good on this, but they're going to be great with understanding natural physical principles. They're going to be very visuospatial. It's really great if you're good at 2 or 3 of these. Things may become out of balance if you are a superstar in one and you have none of the other abilities. What we owe to our patients is to understand them in the context of where their strengths lie and playing to their strengths, whatever that may be. So safeguarding this cognitive reserve is not loading your trunk with junk. I talked about the stress. That's leading to cortisol, which can be some junk. But also, what you eat is important. And unfortunately, I know you're getting a ton of messages about what you should eat and what you shouldn't eat, and we change our minds every 10 years. It's kind of like clothes. Women who have big closets, they know that they keep the flare leg jeans because those are coming back. I know it. And I already told you about the stress, so I'm going to power through that one. Exercise. I have a friend who says, I exercise so that I can eat. Sounds good, but may not be exactly the right thing to do because you need to be attentive to what kind of fuel you're throwing into the machine. There are absolutely benefits to some kind of physical exercise. I understand that there are some people who have bad knees. There are other people who can't afford to join the gym. We can be creative about how you are getting your exercise. The benefits relate to some degree of stress reduction, enhancing the blood flow to the brain, helps contribute to your obesity management, and obesity is a risk factor for insulin, which is a risk factor for all kinds of other things. And in general, it can create social interactions because you're learning how to do the new activity with other people, et cetera. So we're hitting a lot of different buttons when you get some exercise regularly. And by regularly, I mean at least 3 times a week. We have a lot of success when we actually write it down on a prescription slip instead of a medication. And so we're doing that more and more. Again, I would refer you to a PDF that's downloadable from the OBI website because it really gives the executive summary of the impact of physical activity. Everybody's maybe heard of the Mediterranean diet. Try to eat whole grains as opposed to processed things. Things that are white, like granulated sugar or completely processed flour, are more contributory to a hyperglycemic state, and I'll get to that in just a second. But more fish, less red meat, that has to do with the kind of fat that's in that protein. Also, there's something about the serving size of a fish. You don't see people eating a whole marlin. But when we eat steak, we go big, or we go home. And I'm telling you, the amount of protein that you need for the whole day is the size of your palm. Now, Don Stuss has a bigger palm than me, so he can have a little more steak than I can. But I can't even have a rib steak. I can have a hamburger, and that's it for the whole day. That's not hamburger for lunch and then steak for dinner. So I've really changed a lot, and it really has made a big difference for me in lots of different ways. So I highly recommend taking a look at these recommendations. More vegetables, more fruit, more stuff that comes from the periphery of the market as opposed to the middle section. The middle section has the stuff that has a great shelf life of 3 years, but the stuff that's best for you is around the outside. And the sooner we can get our kids onto this page, the better off we will be. Because some of us were brought up with, oh, you had a hard day, I made you a bunch of cookies and milk, and it's comfortable, but I'm driving my glycemic index up, and this is really not good for you because it contributes to your risk of dementia later on. We think of glucose as being important, so why would hyperglycemia be bad for you? But you really need to moderate the peaks, the roller coastering of the blood levels of glucose. And so a lot of people think of, okay, ice cream, obviously a high glycemic index, but actually dried fruit, people don't think about this. It goes down fast, but you just ate 5 apricots. So let's be mindful of these things. I'm not telling you not to eat your favorite food. I'm just asking you to, the first step is acknowledging. And so, there's some stuff that's going to be perceived as treats. Maybe sometimes we're going to have to create a new kind of treat. But we need to actually look at the glycemic index guidelines. The process by which this actually works has to do with the release of more insulin, and it's just the increase in insulin, not full-blown diabetes, that can increase your risk of Alzheimer's disease. When you have hyperinsulinemia, you also increase your risk of having an abnormal body mass index, hypertension, and then, of course, diabetes down the line. So overall, this is a really important part of it. Cerebrovascular disease, you want to avoid. Nobody here wants to have a stroke. But this speaks to getting glucose and oxygen consistently to your brain so that those neurons can connect with each other and function at their best. So that means stop smoking. Actually, there's some data that tell you when you could smoke and get away with it, which is a very interesting concept. And unfortunately, it's not the time of life when most people smoke, which is, those university days when you're trying everything out. It's actually later in life that the smoking has less of an impact on your overall health. Anyway, an interesting thing about our baby boomer population, which actually has a wide range. The early baby boomers on whom we have data about their health, they're more informed than our parents or grandparents were about what you should do for your health, yet they actually have a higher proportion of cardiovascular risk factors and a higher proportion of obesity than those prior generations. We were told ages ago, before Alzheimer's disease research really kicked in, that senility and dementia were sort of synonymous, and that it comes from hardening of the arteries. And we worked really hard to get away from that hardening of the arteries designation so that we could get funding for Alzheimer's disease research and look for those plaques and tangles and understand how they form. But hardening of the arteries actually does contribute to many of our Alzheimer's disease cases in terms of comorbidity and taking away that cognitive reserve. So we need to be mindful of what we're eating, our stress levels, and what other habits we have that may impact blood flow to the brain. What are you doing that's sustainable? So this is the last slide. If you remember only one thing, because you've had a lot of time listening to each other and other people tonight, I would like you to take better care of yourselves. Okay? The better we take care of ourselves, the more we can do for those around us. And so, this is a different way of doing the safe, loved, happy, healthy. Ask yourself, pick a day of the year that you're going to do an annual checkup, because it's hard to do something every day, I know. What am I doing now that I want to stop? That could be a behavior that you don't like in yourself. That could be an actual activity, okay? What did I just say yes to that I actually want to stop? How many of you have one of those things, or two? It's pretty ubiquitous. What do I want to start doing? I went to a talk by astronaut Commander, why am I blanking on his name? He's such a cutie. Chris Hadfield, thank you. See, it happens. He said, in response to a question about was it on your bucket list to become an astronaut, he said, just stop right there. The reason I don't like the phrase bucket list is it means that there are a lot of people walking around with empty buckets. Profound. And so what is it that you want to start doing? And then why is it that you haven't started yet? Do you need to make time for it? What do you want to keep doing? Because I'm sure there's lots of things that you want to keep doing, but it's nice to be able to be grateful that you have some things that you want to keep doing. And then the last item on this list is, what am I going to do in the next 6 months to reduce the stop list and increase the keep doing list? And I guarantee you, if you take the time to go through this and really reflect on it, even once every 2 or 3 years, that shift in those lists will happen. And you will be on that safe, loved, happy, healthy path. All right, we're going to open it up to Q&A. I'll let you manage the time. I know it's already 8:13. If any of you need to get up and go, I will not take it personally. It's late.